Welcome to the show discussing problems and issues of health with Dr. Alcena. For this segment of the show, I want to continue to talk about diseases of the pancreas. When I left off last week, I was talking about the different problems that the chronic pancreatitis can cause. Specifically, I was talking about vitamin B12 as it relates to malabsorption. As I mentioned, I will repeat it again. There are a number of things that can cause the pancreas to become inflamed. This is the pancreas right here. And this is another example of the pancreas as it is attached to the rest of the GI organs here. Okay. Now, anything that can block off these tubes here, causing the enzyme that the pancreas produces to back up into the pancreas, that then causes an inflammation. Okay. Now, the most common cause, of course, of pancreatitis is alcohol. 80% of it. Roughly 20% is gallstone. Now, the gallstone, I had a big discussion a few weeks ago about gallstone disease. I'm now specifically talking about chronic pancreatitis. The chronicity develops because of the constant backing up of the enzyme that the pancreas produces into the pancreas, causing the inflammation. Now, once the inflammation is left untreated, then it becomes chronic, and then the chronicity of it damages the pancreas completely. Now you have the endocrine part of the pancreas and you have the exocrine part of the pancreas. The endocrine part of the pancreas involves the production of insulin, which I talked before, I'm not going to get again. The exocrine part produces a series of enzymes that are needed for us human beings to digest food that we eat. Okay, now once the pancreas becomes damaged, the pancreas is located in the left mid part of the abdomen. And of course, when it is chronically damaged, it causes constant pain, nausea, recurrent vomiting, loss of appetite, weight loss, and staturia, which is a condition during which the stool comes out loaded with fat in it because the fat was not properly digested. It's coming out with the stool, and as part of the malabsorption that's taken place, the patient, of course, is malnourished. He or she is proteinly starved, not enough protein to function properly. In addition to the lack of protein, the patient can have folic acid deficiency, vitamin B12 deficiency, vitamin D deficiency, anemia, in particular iron deficiency anemia, because you cannot absorb iron, plus the anemia associated with that. I will get into that later. And of course, as I mentioned, vitamin D deficiency. When I left last week, I was having a long discussions about folic acid. Let me review that. Folic acid is absorbed through the jejunum part of the small bowel. Iron is absorbed in the duodenum. Vitamin B12 is absorbed in the terminal ileum. And all these organs are affected by the chronicity of the pancreatic disease. So therefore, the whole thing is all swollen, and you cannot absorb these things because you're not getting the proper amount of pancreatic juice, as it were, which is basically enzyme being dumped into the stomach so as to help digestion. So you cannot absorb it, because you need these things in order for them to be broken down properly when we eat the food so that we can absorb it. Now, I gave a long talk about the problem associated with vitamin B12. I'm going to take some time again to give you an overview of how complicated, fascinating clinical medicine really is by giving you a discussion about vitamin D. Okay, vitamin D cannot be absorbed as well in this setting. Okay, so what's the big deal? Well, the big deal, the person develop vitamin D deficiency. Well, how do you go from vitamin D deficiency as a result of pancreatitis and you have chronic pancreatitis? Well, here's the deal. If you need sufficient amount of vitamin D to do a whole bunch of stuff in the body, including controlling the blood pressure, because when the vitamin D is low, the lowering of the vitamin D insufficiency causes overactivation of the renin renin-angiotensin-aldosterone pathway. The overactivation of this pathway causes the blood pressure to go up and makes it even more difficult to control the blood pressure when someone, of course, is being treated for high blood pressure. Now, I want you to understand the magnitude of this. 90% of folks who are dark-skinned like myself have vitamin D deficiency, regardless of what they call themselves, who they call themselves. It really doesn't matter. As long as they're dark-skinned, they're going to have 90% of them have low vitamin D, unless, of course, they're working in the farm under the sun all day long, like I did when I was growing up. I see people getting a tremendous amount of press for having been poor and gone to medical school and become a doctor, blah, 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 blah. That is true. But I worked on the farm for 10 years, from the time I was 9 years old until I was 19 years old, 8 hours, 5 days a week, barefooted, bareback, and temperature 100+ degrees in Haiti, walking barefooted. I work on the farm. I picked cottons, I cut sugarcane, I planted rice, I planted corn. I did all that stuff. If it was a work to be done, I did it. You say, well, they must have been paying you a whole lot of money. Of course they were paying me. You know how much I was making? I was making exactly 1 Haitian good per day. And 1 Haitian good per week, per week. And 1 Haitian good is the equivalent, it's a 20 cents per day. In those days, it was equivalent to $1 per week. That's what I was making, 20 American cents per day I was making. So I would have had high level of vitamin D because I was in the sun all the time. But you have folks here, 1 out of every 2 adults, black, suffer from hypertension. And I just finished telling you, 90% of them have low vitamin D. So if you have low vitamin D on the basis of your skin color, and then you have a propensity to have high blood pressure to begin with, now what chance do you have of having your blood pressure well controlled unless you happen to be fortunate enough to run into physicians such as myself who really practice what's called ethnically associated medicine so that you could properly get the right medication to treat your blood pressure. Now, 70% of white folks have low vitamin D as well. So this is a major problem. Now, once you get the low vitamin D, a whole bunch of stuff is going to happen. What's going to happen, I'm going from chronic pancreatitis, secondary to whatever. I mean, you know, there are a whole bunch of stuff that can cause the pancreas to get sick. If you could get sick from Ascaris, which is a parasitic problem that can clog up these tubes right here, and the acid, the enzyme backs up. You can get it from Chinese fluke. The Chinese fluke can also cause it to happen. It block up the tube and it backed up. Okay, if you have M.A.C.P, you could develop pancreatitis. If you from the islands like I am from, there's a fruit named ackee, which is extremely delicious. What's interesting about ackee, if you eat the raw ackee, it can drop your blood sugar. It can also cause pancreatitis. Raw ackee causes pancreatitis as well as low blood sugar. The raw ackee that is nice and ripe is absolutely delicious. I mean, 100% delicious, delicious fruit, okay? And it's throughout the Caribbean. We have it at different parts. We have it in Jamaica, Trinidad, whatever. So the point to be made is the fact that once you have chronic pancreatitis, a whole host of other medical conditions can happen. And I'm just giving you an overview of where vitamin D will become low. Because low vitamin D, you can also develop osteoporosis, okay? How so? Well, once you have low vitamin D, if it remains chronic, you're going to wind up with secondary hyperparathyroidism. That's right, secondary hyperparathyroidism. And that then causes osteoporosis. And then to make matters worse, it causes kidney stone. I mean, I can go on and show you all the detail that can happen because of chronic pancreatitis. So let's go then to talk about iron. You cannot absorb iron either. Ordinarily, the iron is absorbed in the duodenum part of the stomach. Well, can't absorb it because you don't have the necessary enzyme that is needed to properly metabolize, digest the iron so that you could absorb it, okay? You can't do it. So therefore, the person has 2 types of anemia. They have an anemia of iron deficiency because they cannot absorb iron, okay? On top of that, they have anemia of chronic diseases because the pancreatic that is chronically sick is a chronic disease. It's an inflammatory process that suppresses the bone marrow from being able to produce early erythrocyte to begin with via the lack of the ability of the transferrin protein to carry the iron that is attached to it into the pancreas. You can't do it. I mean, into the bone marrow. I'm sorry, can't do it because it's backing up. So you have multifactorial anemia. Okay, now you got to understand these things. Okay, this is what academic clinical medicine is. It's not just the raw, everyday stuff. You have to understand the detail of stuff if you're going to really fully provide the care that is needed for people who really need it. So you have this iron deficiency because you have chronic pancreatitis. Now that I've gone over some of the major problems that are associated with vitamins and ions and so on and so forth, now let's go back to the symptoms again, which is chronic recurrent left upper abdominal pain, nausea, vomiting, diarrhea, in particular diarrhea that has a lot of fat passing out in the stool. Okay, all these things can happen. Another condition that I forget to mention, and I should mention it here, is the fact that there's a disease called cystic fibrosis. You heard about it? Cystic fibrosis can also cause pancreatitis. Okay, so you got to keep that in mind. And it can also become chronic pancreatitis. So it's not just alcohol and gallstone, etc. All these things can cause it. Okay, and there's also hereditary abnormality that can cause pancreatitis as well. All these things can happen. Okay, so now that you've got the symptom, the patient will present telling you what's going on. You take a history from the patient. You ask about alcohol abuse, etc., all this other stuff with the travel and so on and so forth. You need all that, and you're going to carry a complete physical examination, naturally. Take the vital sign, listen to the lungs, listen to the heart, examine the abdomen. You pay particular attention to the left mid-abdomen, which is where the pancreas is located, to see if there's tenderness there and so on and so forth. And then you completed your exam, you're going to do a rectal exam, etc. Now, you're going to do some blood tests. Okay, now, what kind of blood test you're going to do? Well, you're going to do a complete blood count. What is the value of the complete blood count? Extremely valuable, because as I stated, the patient may have anemia. Well, you don't know what type of anemia. What the blood count will give you an idea what type of anemia it is, because you're going to get the red blood cell indices. If the patient has iron deficiency anemia, which is iron deficiency anemia, the MCV is going to be low, microcytic. Okay, if the patient has either folic acid deficiency or B12 deficiency, when you look at the result of the blood count, you're going to see macrocytosis. The MCV is going to be high. Okay, so that's the value. And we're going to give you an idea of the value of the blood count. You have to look at the totality of it. The white blood cell count is likely to become elevated because the pancreas is inflamed. Inflammation will cause leukocytosis, elevated white blood cell. Okay, infection or inflammation can cause it to go up. Okay, so that's the one you look at. Now there's another piece of the indices that is not really part of the indices, but the computer will give it to you, something called RDW, red cell distribution width. Very crucial, because it gives you an idea. You got to be careful here, because I just finished telling you you're going to have a combined anemia. So don't necessarily assume just because the RDW is normal, that means the patient doesn't have folic acid deficiency or the patient doesn't have B12 deficiency. You could miss the boat if you assume that, because you have an inflammatory process going on. So you're going to have a combined anemia. Microcytic in combination with macrocytic may normalize the RDW. So that might confuse the heck out of you, and then you fail to do your folate level. You fail to do your B12 level because you're looking at this thing as, oh my God, the red cells are normal in size, so how can the patient have completely wrong? False, wrong, whatever term you want to use, okay? So you got to be very careful. So you can go ahead, do the blood count. You finish with your blood count. You're specifically looking at the white blood cell. You're looking at the red blood cell profile. You look at the platelet count to see if it is low or high. Either one can happen, because in chronic inflammation, that can cause the platelet to go up. It can also, acute inflammation can cause it to go down. So you have to take a look at these things. So now that you finish with your blood count, you're going to go to do some chemistry tests. Well, you're going to do a complete chemistry profile. Complete chemistry profile, which involve the renal profile, which involve all the electrolytes. The blood sugar is tested, and then you move on to the liver function tests, which include the bilirubin, SGPT, SGOT, alkaline phosphatase, that kind of stuff. Take out the total protein, because I just told you the albumin is very important, because this patient is likely to be malnourished, maybe protein starved, so which means that the total protein may be low. The albumin is likely to be abnormally low as well, because the person is malnourished, protein starved. Okay, all right. So now that you did that, you're paying very close attention at those results that the chemistry profile is giving you. And to add to that, you're going to do a serum amylase, you're going to do a serum lipase, serum amylase. You're going to do these things, because the serum amylase is likely to be elevated. So there's the serum lipase is going to be elevated, because in acute pancreatitis and or chronic pancreatitis, the amylase and the lipase are abnormally elevated. So you're going to do these things. Very, very, very crucial to pay close attention to these things. And then I mentioned to you that the vitamin D can cause a whole lot of problem, but it can lead to kidney problem. Yes, it can lead to kidney abnormality. You could go on to develop renal tubular acidosis secondary to the vitamin D deficiency. I realize that I'm putting a whole lot of stuff on you, but that's the only way I can do this. You got to really be thorough. And besides, so many folks at different levels listen to the show, and I want them to understand the basics of these things so that they really have a full understanding of what's going on. So you do all these things. Now that you take all this stuff out of the way, now you're going to get involved by some radiological evaluation, which is crucial. Well, the most important radiological evaluation to do in somebody with a pancreatic disease is the first test would be an ultrasound of the abdomen. Okay, you do an ultrasound of the abdomen. The radiologist will have a chance to look at the gallbladder if it's still in situ. Take a look at the pancreas, what's happening with it, how swollen it is, how shrink it is, how chronicity, all these things can actually be seen. So you do the ultrasound, okay? Now, you want to follow that up by doing a CAT scan of the abdomen with contrast. That really gives you a complete overview of the intra-abdominal organs, including the liver, the pancreas, the gallbladder, if it is in situ, the spleen, and all these other stuff, the bowel. It gives you an overview, so you really have a complete evaluation of what's happening with the pancreas right there. Okay. So now that you've done all these tests, the next problem is management. Management, the patient is likely to be in recurrent pain. If the patient is chronic at home, being taken care of as an outpatient, you got to be very sensitive to provide sufficient pain medication for this patient who's in chronic pain. Diet plays a major role. The more fat you put in the diet, the sicker the patient is going to get, because the pancreas is going to be forced to work harder to try to dump enzyme into the stomach to digest the fat that the person just ingested, when the pancreas is incapable of doing that because the pancreas is sick. So you got to be very careful to have good dietary management constantly. Now remember, this patient is likely to become diabetic as well, because the endocrine part of the pancreas is being destroyed. Remember, you have two parts to it: the endocrine part, the exocrine part. The endocrine part contains the production of insulin. Well, the pancreas is now chronically sick, damaged. This person is likely to have type 2 diabetes with all its complication thereof. So type 2 diabetes is type 2 diabetes. It doesn't matter how you got it. what was the basis for why you got it. Once you got it, okay? So, and then, if you think that was the worst of it, there's more to it. Now that you've done all that, there's a subgroup of patients who go on to develop what called pseudocyst of the pancreas. Pseudocyst of the pancreas. This is a cyst that's full of fluid because of all this emptiness. See, the pancreas, when it is damaged, all this inside of it becomes empty, and the cystic emptiness, and you have cyst development, so you have pseudocyst of the pancreas. And it is not unusual for the pseudocyst of the pancreas to develop an abscess. I mean, I can go on and tell you all this stuff that can happen. So you develop an abscess. You have to be prepared to deal with all these things by looking for them. Because if the patient has a pain that's not going away, a white blood cell count that's not coming down, a SED rate that's not coming down, it tells you it's a chronic infection that may be more than just the inflammation. There is a way, and there are ways, of discerning inflammation from infection. I'm not going to sit here and tell you all that, because it is not my job to tell you everything I know. That's never going to happen. But believe me, I have ways, and others know those ways as well, on how to discern infection from inflammation, okay? And then, of course, if the patient is inside a hospital, clearly fluid management becomes very important, because the patient is being kept from food because of the pain and the nausea and the vomiting, and this patient has to be hydrated with fluid that contains sugar. Absolutely. Normal saline is water and salt. It's not food. The patient needs food, and sugar is food. So you have the fact that the patient is diabetic means nothing as it relates to the need to get proper fluid. The only syndrome in diabetes mellitus that one does not introduce sugar to the body is hyperosmolar non-ketotic problem. That's it. Any other syndrome, the patient cannot use sugar. That's why he or she is so sick. So therefore, you would look for an excuse to give the patient the more insulin, the better, so long as you give the patient sugar. You get the patient the sugar, replace the electrolyte that are needed to be replaced, and don't be afraid to do that, because you have insulin to give the patient. In fact, insulin is an anabolic steroid. You're looking for every excuse you could come up with when somebody is very sick to make them better by putting them in an anabolic state. Well, what better medication to use but insulin? So it is ridiculously absurd to back away from giving somebody who is very sick sugar just because he or she may be diabetic, which is precisely what you need to do, because the inflammation, the infection, whatever it is preventing him or her from using sugar to begin with, even the sugar is in the body. So you need to give sugar, give insulin. The insulin pushes the sugar into the cell, the patient build up and get better. I understand those are difficult processes. I understand that some folks were not taught that way, but I'm telling you, this is the way to do it, period. And you get your patient better quicker. Okay, so the patient needs fluid management, keep the patient NPO, pen medication, electrolyte replacement, and then you monitor the situation by giving the person, you repeat the CAT scan, you introduce antibiotic. Any GI infection requires antibiotic that's going to cover anaerobe. That's correct, to cover anaerobe. You need to know that. You can't just take any old antibiotic and say, this will do it. It doesn't work like that. And then a very good antibiotic that covers anaerobe that comes right to my mind is Zosyn. You give the patient Zosyn. You could add whatever else you want to add to cover gram-negative, gram-positive, etc., such as vancomycin, whatever. The patient has to be treated because there's an abscess there. And you may need to call your surgeon, because you can't treat an abscess properly with just antibiotic. It may have to be drained. It may have to be taken out. That's a surgical decision. I'm not a surgeon, so you have to make sure you have a surgeon, general surgeon, who's good with GI surgery involved, because the patient you can give you antibiotic to get it started, But unless that abscess is drained or taken out, it's not likely to be gone away very quickly. Okay, so this is how you go about managing somebody with chronic pancreatitis. Unfortunately, some folks who have chronic pancreatitis as a result of alcohol, they go back drinking again, even though they know they're not supposed to drink. You tell them, you had discussions with them, how bad the alcohol is. Well, alcoholism is a psychological / medical problem. It's not the patient's fault. He or she has a psychological issue that's causing him or her to abuse alcohol. Okay, in this country there are 19 million documented alcoholics, chronic alcoholic folks, and there are many more millions that's not documented. It is a serious problem. It causes devastation to families and causes car accidents and people getting killed and getting injured, all kind of crazy stuff. And this is unfortunately a serious problem. Okay, I spent almost 8 years working at a hospital in Westchester for a major university that shall remain nameless, working on the alcoholic floor and the substance abuse floor, teaching the interns and residents in psychiatry how to manage these things. Believe it or not, when I was honored, receiving this great honors of M.A.C.P., unknown to me, one of the things that was cited was the work that I do in substance abuse. And yet I'm not a substance abuse expert. I don't practice substance abuse, but I did do it for almost 80 years at this place in White Plain where I worked there. And I was recognized by that plus the dozen other reasons why I was recognized, why I became an M.A.C.P., etc. So suffice it to say, I know what I'm talking about. Okay, so chronic pancreatitis is a major problem, and it has to be dealt with. And I did what I could by explaining it to you. Next week, I'll talk about something else. Until such time, keep watching the show. This is Dr. Alcena saying so long and bye-bye.